what we're going to be talking about today is kind of a strategy for retreatments. And as always, we start with why. And obviously, you're all endodontists. This is what you all signed up for. You're going to be redoing a lot of root canals. I have multiple ones today. You'll also notice that as the economy becomes a little bit more sus, you're going to be doing more and more retreats or more and more cases where somebody else started the case and went into it. So having these tools in your back pocket is really important. And the reason that we need to do root canals, or that root canals need to be redone, is generally bacteria, right? Somehow an infection has either got back in there or it was never cleaned out well enough in the first place. And so that's kind of the historical model for when we think about why retreats are necessary. It's because somehow bacteria are causing a reinfection inside the tooth. What I want you all to remember is that we never sterilize the tooth. You guys have seen the SEMs that Gary Carr posts. There's almost always something left inside there. And we're not going to get into the root cause bacteria stuff. I'll do a completely different lecture on that. But that's one of the things I think that the AAE failed at, was we were going around saying like, oh no, we eliminate all bacteria and that causes success. And we see plenty of cases where there's clearly something that wasn't cleaned out well enough and it's still working. And so the question is, why is that? And what I want you guys to start thinking about when you're looking at retreating teeth is that there's this interplay between the bacteria that are going to be there, no matter what fancy toys you use, no matter how much stuff you throw at the tooth, and the patient that tooth is attached to. It's a really big thing for me, is that the patient matters a lot in the prognosis. And what is their immune system doing? And so this is a concept that I kind of learned a lot about during the COVID times, is that there's this idea of your immune system has a spectrum. You can have almost no immune system, in which case you're going to have a lot of infections all of a sudden. And then you can have a hyperactive immune system, and now you start to have chronic inflammation and autoimmune disorders and things like that. And this is a spectrum that's constantly changing. So if somebody all of a sudden starts to get sick or stressed out and they don't take care of themselves and don't sleep, well, they may start to drop down a little bit and become more susceptible to infections. On the other hand, if they start to get stressed and not sleep, their body may do the opposite. It may go into crazy high inflammatory mode. And all of a sudden you see things that were working no longer working. So right now, obviously your focus is going to be on technically, how do I get the stuff out of the teeth? How do I find the missing canals? Broken files, all sorts of stuff like that. But when you start to master that, I want you all to consider taking a step back and remembering there's a patient attached to it. So what can we do to modify the patient? We can do a lot of things to modify the tooth, but what can we do to modify the patient so that the tooth that you work on has a much better chance of success? With that being said, let's talk about a strategy to retreat teeth. And what I want you to think about here, when I lecture to general dentists, I kind of give them more of a recipe. Here is a average. This should work for most root canals. You're good to go. But your job as endodontists is to have every tool in the toolbox. And you can have your standard kit of, all right, just like Emmy and I were talking about. You start with an F1, blah, 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 you use chloroform, whatever it may be. You have your standard way of removing the stuff that's inside the teeth. But you need a deep bench, because with retreatments, there's a couple things that are true. Number one, they almost never look good when you're done. But as long as they work, that's all you got to care about. And number two, they're never predictable. The retreats are always different. Sometimes they're super easy. Sometimes you have to pull out every trick under the sun. So what my job is to do is to give you all every trick under the sun. And then your job is to go and use that big brain and figure out which tool you need to use in this case. I think of it as like a big sound mixer. We can all look at it and see that there's these little lights going up and down. And it's like, okay, I'm going to start tweaking these little things here and there and I'll make it louder or whatnot. But a professional sound mixer knows how to use all of those tools to adjust the gain, the highs, the lows, the echo, the reverb, whatever it may be. And they know how to adjust every single setting to make it exactly as good as it possibly can be. And that is kind of your job as an endodontist when it comes to retreatments, is you need to think like you're the sound mixer and you have 100 different switches and levers you can pull and twist. And it's not just do this one thing and you'll always have success. So with that being said, this is why sometimes single visit endo works great. Single visit retreat works great. Sometimes you can just retreat one, sometimes you can adjust the bite and the little infection at the apex goes away. And sometimes nothing works and you throw the entire kitchen sink at the stupid tooth and you're into it for a year and finally you decide to pull it, because the only way to truly get rid of the infection 100% of the time, and this isn't even always true, is to extract the tooth. So we don't want to do that. We want to save teeth. That's our mission and that's our goal. But just remember, all of this is on a spectrum and it's a lot wider than you've probably been taught traditionally. So why is it that this happens? And of course, we got to have a Simon Sinek in there. Well, when we look at the reasons for failures on teeth, these are kind of the generally accepted ones. And the number one, which I do all the time, is untreated anatomy. I am always finding missed MB2s. I do one of them a day. Like, it's super common. Find your MB2s. Go trough between the mesial and the palatal. Trust me, there's probably something there. If you go down 3 millimeters, there almost always is. You can have it where they don't obturate all the way down, or they leave stuff at the apex. That was kind of what you saw in the case that I showed you earlier today. Separated instruments, we'll talk about those, but sometimes those can cause issues. Sometimes the material choice itself can be toxic or cause issues inside the teeth, or it can wear away over time. Recurrent decay is another big one. That's actually probably what caused yours to fail, Emmy, that you were showing me, is if bacteria can get back inside there from leakage, doesn't matter how good the initial root canal is, it's now going to be bathed in bacteria and they're going to all wake back up. Fractures is a really big one. And so we want to be cognizant of this and try to keep our shapes as conservative as feasible to try to minimize the risk of fractures. And then those final two are what I talked about. You can have hyperinflammation where all of a sudden that other, by the way, that patient who had what I thought was a lateral periocyst, he noticed that he all of a sudden started to have a lot of pain when both of his parents died and he had to deal with all of the funerals and going through their estate planning stuff. That's when the pain started. The root canal was 5 years old at that point. And I think I've mentioned this before, but in general, if you're going to see a failure because of bacteria reasons, it's usually going to happen before that 5-year mark, unless something changes. There's a new crown, they go on a new medication that modifies their immune system, they have a new diagnosis. If it's after that point and nothing's changed, it's more than likely a fracture. So that's kind of your rule of thumb, is that 0 to 5 years, usually that's when the bacteria will wake back up. Anything after that, more than likely a fracture, unless there's one of these changes. And then immune system changes. We see this a lot where patients have had long-standing lesions that have been there for 20 years and don't cause any problems. All of a sudden, they start chemotherapy and go through something that modulates their immune system, and that tooth blows up when they have no immune system, which is the perfect time to do it. So those are some of the times where I'll actually be more aggressive. I'm very much on the conservative side when it comes to not retreating asymptomatic lesions. There are big air quotes there because that has a lot of connotation with it. But on patients who are going to be undergoing some of these more nasty things, anything that the bone modulating factors, whether that be the bisphosphonates or the new ones, or if they're going through chemotherapy or radiation, I will be a little more aggressive there because it's a lot harder to treat and fix once they're in the thick of everything. So, any questions so far? Excellent. Let's get some stuff out of the teeth. So these, for the rest of the entire time, we're going to be talking about getting things out of teeth, and we're going to be starting with how do we cut a hole inside the crown. And so the first thing is our goal, which is to remove all the restorative material above the chamber without removing any dentin that we don't have to. So if you have to find a missed canal, you may have to, access more. But we don't want to make the hole bigger than what was done previously, because most of the time the tooth is failing, and it's probably not because it was too small of an excess, depending. So we're going to differentiate the hard restorative material into crowns, amalgam, and composite. We'll go through this pretty quickly. And if you guys want to have copies of this, I put in here exactly what I use, because a lot of people care about these sorts of things. But For round burrs, there are 3 different types of round burrs that I use, and these are all to just get through material. So the first one is going to be these tiny little purple diamonds from Brassler. They're absolutely fantastic. They are an 012, so they're 1.2 millimeters. It's the smallest round burr that I can find. I'd love if they made a 010. They do technically make an 010 on top of a long skinny guy. That's one that I keep in my back pocket for random times. Next one is a more just general diamond burr. This one's a lot cheaper. These Brassler ones, I think, are almost $8-9 a burr, and they only last about 1 to 2 teeth. These guys, I think, are about 75 cents, and they last multiple teeth. That's so you want to kind of be cognizant of these things when you own a practice as well, as kind of keeping costs down. But this is an 018 burr. It's a little bit larger. Works great for removing composites as well as PFMs and things like that. And then the final one is a carbide burr. We've had a lot of discussions offline about friction grip versus latch. I greatly prefer friction grip for removing caries, but if you want to use a latch one, that's fine. It is important to have it be surgical length, though, because most of the time when we are removing caries, it's big. There are probably some general dentists who are going to watch this and balk at me using an 8-round burr, and I'll show you the cases where an 8-round burr is a hot dog in a hallway inside the final carious lesion because it's so stinking big. We aren't dealing with the tiny little ones. So it's, by the time they get to us, they're big. So I have 6 and 8, both in surgical, and most of the time I use it. We do not access teeth with round burrs. Okay. If you do this, JK is going to find you and he's going to haunt you, because this is how we gouge the crap out of teeth. We use round burrs to remove existing restorative material and caries. For everything else, we use pointy burrs. I don't think any of you are old enough to remember the MasterCard commercials, but I found that funny. Okay, so for my pointy options, this is my metal one. This is from Microcopy. It's called the Max 2. It works great. The problem is they tend to burn out pretty quickly. SS White makes great white burrs that are really good for this as well. For my everyday one, it's an 850 012 Super Course. Right now, I get them from CDI. I've gotten them from Microcopy. I've gotten them from a few different companies over the years. It was ever cheaper. I use this on literally every single patient. That's why we call it the workhorse. I use this every single day. This is what I trough for. This is what I access with. This is what I refine with. I remove excess gutta-percha with it. It's on every single burr block every single day. And then the final one is a slightly larger one that I use for cutting off crowns and for crown preps. Sometimes for large composites, I'll use this to remove it, but most of the time the round burr works just as well. And that's an 08188C, and it works really well for cutting off crowns. The reason I like this for cutting off crowns is the thickness of that diamond is perfect for the crown splitters. Now, there are 2 different crown splitters. How many of you learned how to use this big boy right here? Did you guys have this in dental school? Couple. How many of you learned to use the smaller hand one? Okay. The benefit of this big one is you can create a lot of force. If you notice, it looks like an elevator. The downside of this one, it's an elevator. So you can break teeth with it. So I prefer to use the small one here. It gives me a little more finesse with it. For someone like Emmy, you might need the extra force. Just kind of depends. I know you've been benching, girl, so you're getting up there.
Talking smack.
2 plates either side. Let's combine this out. Let's go. But that's something to kind of consider, is with the the amount of force that you want to do, and then you just want to have a pair of hemostats. I think you all know how to remove crowns. If they're bonded, they're really annoying because you do have to cut the entire things off. Most of the time, they're cemented, and this works pretty well. Cut a hole in the buckle, put this in there, crack it, and it pops off pretty easily. Okay. Ultrasonics, and they can be used to remove this hard material. And so this is one of those switches, those small little things you got to keep in your back pocket. This is from Halsey. This is actually designed to cut off gutta-percha, at the pulpal floor. And I discovered that this thing's great because you can crank it up to 100, and with lots of water, it almost melts amalgam deep down inside the chamber. It's actually really cool. You put it in there and the almost just like melts away. And getting out those deep amalgam cores is one of my least favorite things to do because they don't make a burr that can really do that very well, unfortunately. And if you actually have amalgam cores or composite cores down into the canal space, which sometimes people will do, these little diamond tipped ultrasonics actually work really well to pop those out of there. Generally, because of the C factor, they're not really well bonded in there. So the ultrasonics will vibrate out the piece and you don't really have to drill it out because they're very difficult to drill that far down there. I hear many of you saying you haven't covered posts, and you are correct. So let's cover posts. There are 3 different types of posts we're going to have to remove. We have our metal, we have our fiber, and we have the dreaded cast post and core. So for metal posts, I've told you guys to buy this before, right?
We have.
Okay, good. I'm going to put Penny next to everything. You guys have asked me what things you all should buy in residency. I know you have no money. There are a few things that will make your life so much easier. It's worth spending the money on. This is one of them. I brought a VibraPost to every office that I worked at because it is that useful for removing posts. You look at it and it pops it out in like 5 seconds. It's the best thing ever. And the other thing you're going to need is some form of skinny, like diamond tipped one to go around the side of the post. I have found that the Halsey one is my favorite. Pick your favorite. There's a bunch of them. They're all designed pretty much the same. So how do we remove the metal posts? The first thing you're going to do is remove the bulk of the restorative material with diamond burrs, because it's usually going to be some sort of composite or the cement that's holding it in place. You take that down to about the pulpal floor. Once you remove that, you then use that skinny diamond alongside the post itself, aiming at the composite or the cement or whatever is holding that post in place. You want to dislodge the bond or the cement between the post and the tooth. And what you'll almost always notice is that it sticks to the post, not the tooth. And that's because the C factor is terrible that far down. It doesn't bond very well. And those vibrations disrupt the one little dentin tag that's holding it into place. So that's your next step. We're slowly troughing down around it, but you want to use more vibrations than anything so it breaks it loose rather than removing dentin. Then what you're going to do is crank the power and for sure crank that water, because this will heat up the tooth like crazy up to the highest level it can go. And the VibraPost is really cool because there's a little notch cut out of it. And that notch you can fit perfectly against the post. And what you're going to do is, if this is the post and here's the notch, you put it like this and push. And that lateral motion with it activated at 100%, make sure you crank this. You actually use the little, what's it called? The ultrasonic wrench thing to make sure it's fully set in place. It will have your post out in 30 seconds. It's really impressive. If it is a parallel post, these things pop them out almost immediately. If it is a screw post, you will have to unscrew it. It is sometimes difficult to remember when you're looking upside down in the mirror, the lefty loosely, righty tighty. But sometimes I'll actually okay, wait, which way is okay. And then do it. So you actually have to back it out. When I back out the post like that, I usually use this little guy, activate it, and reverse it as I'm going out. And that usually pops it out. You can also, if you're brave and it's a thick post, you can hit it with the big fat diamond if it's getting a little bit loose. Oftentimes that'll chatter it and pop it out for you as well. So there's many different ways to get metal posts out. But the thing to remember, these are easy. I do not sweat at all about getting a metal post out. If it's huge and you're gonna break the tooth in, sure, go do the apico. But most of the time, big fat post in a palatal root of the upper molar or a lower distal, these come out super easily. It doesn't add any time for me to get out a metal post. Fiber posts, on the other hand, suck. They are terrible. I absolutely hate getting fiber posts out. And the reason why is you can't vibrate them. They break. So if you can't vibrate it out, you have to drill them out. And this is about as easy to do as driving through a school bus. It absolutely sucks. So in order to get these out, The good news is most of the time you're only going to go in short little increments before you want to air dry and see anyway. So I only activate the ultrasonic for maybe 3-4 seconds before I want to come in with air and cool it off. So you're not going to create the same amount of heat that you would with the big VibraPost getting inside there and holding on to it for 30 seconds. This is nice because the way that we are able to remove these is the VibraPost is a different color than the dentin. So it almost looks like a bullseye where you have the kind of gray VibraPost in the middle. You usually have a white layer of cement or composite, and then you have the dentin. And your goal is just to follow that down as far as possible. So I generally will start with the 850, the workhorse, kind of dropping down a couple millimeters at a time. Then you need to move on to something smaller and longer. And so you could use one of the ultrasonic tips if you feel comfortable with that. You could use, this is the Endo Guide burr from SS White. This works pretty well this works well too. I like the one that goes into the high speed, but they have many different shapes that work in both latch attachment and friction grip. Munspurs are also pretty darn good for this as well. And I will pull a penny on this one. If you guys don't have Munspurs in the clinic, they are useful to have. I know you do. Perfect. You're only going to use these two. A half and a quarter are all that you ever need. You don't need a 4. So if you don't have them, or if those are missing, just buy those. You can also usually, if you're at the AAE and you come up and we kind of just go talk to you can usually get you one because they're such a useful tool. I don't use them as much anymore, but in residency, they were a really good tool in my toolbox. They come in 3 different lengths. Everyone should at least have a set of Munspurs. I have a set of Munspurs because they're useful. And it's one of those things you pull out of your pocket every now and then. Okay. The other one is to have the strop go tip for your air water. I think we have, you guys have in like one room, right?
We got some.
Excellent. Cool. These work incredibly well. And these are what they look like. They're from Vista Apex, and Penny won't even look at me because I'm not going to recommend you guys spend $125 on these because you can get them on eBay for $13. And so definitely a really good tool. I have them on, you saw I have 2 of them on my cart, and they do come in a longer set as well. That's really nice for the assistant side because they're going to be farther back from the tooth. And so that longer side allows them to get in there. For our side, Penny's excited for that one. For our side, I just use etch tips. They're very cheap. You can get 400 of them for $18. That'll be enough to last you your entire residency. So that's what I use. On the assistant side, I actually have a slightly larger gauge because they don't go inside. I don't have my assistants go inside the tooth itself. You want to be careful about using too high of an air pressure inside the canal or the chamber itself of the tooth, because there is a risk of an air embolism where you blow air out the apex. That causes like the crackliness. It can cause black and blue. It's not a good experience for the patient to go through, not a good practice builder. So you want to limit the amount. You're not going to be able to create enough pressure with the etch tip. No matter how high you crank it up on your cart, there's laminar flow exists for Bernoulli's principle, I think. Bernoulli's with a B. Anyway, they squared. All right, I'm done being a dork. So these also work really well. So definitely have these here. And what you want to do is air dry. So spray out as much of the water that's inside the cannula as possible, and then desiccate the whole thing, because that is going to show you those color differences as you're getting farther and farther down the canal. And pretty much you just work your way down. And they suck, but usually these aren't placed very well, and they're only go down about 3-4 millimeters, and they pop out, and all of a sudden you see pink. As long as you're not seeing red, you're good. Okay, cast post and cores. How many of you have had to retreat a cast post and core yet? How much fun was that? Wasn't. These suck. And the way that you want to think about cast post and cores, you take the cast post and core and you turn it into a metal post. You remove the outside and you create just the cylinder. And the general way you're going to do that is by using those metal cutting burrs. The problem is you're going to use 500 of those metal cutting burrs because you're going to dull them almost immediately. And the reason that they're so difficult to cut is when they cast them, they're not using the same soft metal that you would for a regular post. They're using the same stuff you use in RPDs, which is incredibly hard. So it takes a long time to drill through these things. It sucks. Your hand's going to be tired. Electric handpieces help a lot with this, though. What I would love to see is if we could take something that has the length and the carbideness of an 8-round burr and combine that with my big prep burr. This would be a perfect amalgam / turn a cast post into a regular burr. But unfortunately, that doesn't exist. If anyone from Browser is watching, let's make this thing. I would love to do that instead. So that is, and then once you've made it into a post, it's the same thing as removing a metal post. It's cast posts aren't hard once you make them look like a regular post. It's making them look like a regular post. That absolutely sucks. So, any questions on taking out the hard materials, your crowns, your amalgam, your composites, your posts, that sort of thing? Okay. Most of this was what you did in dental school. I wanted to kind of give you a few extra tips and tricks that might work for different things. Obviously, you're not retreating fiber posts in dental school, but go ahead and if you have a question, I can't see everybody because it keeps zooming in. I can just see your hand, Leighton, so you can ask your question.
When do you decide to take a crown off or a section of bridge? Do you contact the general dentist most of the time before you do that, or do you just?
Depends on the patient and the general dentist and kind of our relationship. So oftentimes, if I'm going to be cutting it off, it's because there's some recurrent decay, right? It needs to come off anyway, and I need to see how much is left. So if I don't think it's that bad and I'm going to 2-step it, I'll have the patient or I'll have my team make a triple tray impression using Blue Bite so you can kind of see what it looks like beforehand. So they can either scan it with their scanner or use that to make the temporary. And then I will just access, but I'll do a big hole. And with the large hole and just remove the restorative material, I can generally see, okay, how bad is the caries? And if I get through the composite and there's still a nice dent on the outside, I know, okay, we're probably going to be okay. Retreat it, put calcium hydroxide in, tell them, hey, next time I'm going to be cutting it off. We'll arrange it so you go from my office back to your general dentist to get everything done. Because patients do not like it when they're missing a crown for a month or any time at all. So that's the first one, if I'm restoring. If I'm not restoring and I'm concerned about restorability, then I will often I'll stop and call the dentist and say, hey, what do you want me to do? Sometimes they will actually see the patient back, cut it off and re-prep it with a temporary on it if they think it's savable. That's one way to do it. Bridges are a little bit harder because you're generally losing at least 2 teeth when you cut off the bridge. So patients tend to not like that either. So it's a balancing act of talking to the patient and their needs, talking to the general dentist, and you can usually tell when you get inside there. So I had one recently where I could see there was some decay on the buccal. It was a bridge and it was going to be a retreat. And I was like, well, I made the hole bigger and I got inside there and it was mush, just straight bush. And I'm taking that big 8-round burr and it's sinking down into everything. And by the time I got I didn't even get all the caries out because by that point it had gone into the furcation on both sides. And that was all right, you need this out, put some calcium hydroxide in there, shove it full of cavit, tell her to get it extracted. So you can usually, if you make the hole large enough, you can usually see what you need to do if you're retreating it because of caries. That answer your question?
Mm-hmm.
Cool. Any other questions, guys? Cool. For some reason, the camera just loves you, Leighton. It just keeps zooming right on you. I know it's very funny. This camera's, oh my God, it's following you. Okay. Let's get to what you actually came here for. How do we take out the crap inside the teeth? And so that is a variety of different things that you will have to remove from teeth, and they're always coming up with new ones. So we're going to take these one at a time. We're going to start with Gutta-percha, but your job as an endodontist is to shove every possible crazy idea that I'm going to throw you and that you learn and that you see online and you see on Instagram and you hear from your friends, throw all of those into that big, beautiful brain of yours. Start off with kind of a, here's what I'll do in most cases, but be prepared to pivot, because retreating teeth are weird. It's not easy, and there's always going to be a curveball thrown at you, as I assume many of you have already discovered that. So Gutta-percha does come from a tree. We all know that. This is actually a QR code to a BBC mini documentary that I found quite fascinating, and it tells the history of Gutta-percha. And turns out it was originally used by the British to wrap transatlantic cables for communication. So the British had a problem. They had all of these colonies back in the 1800s, but they didn't have any way of communicating with them. And so it'd be 3 months on a ship to get to there. And Gutta-percha, they discovered that it would hold itself around the electrical wire and is resistant to salt water. So they can now use communications back and forth. So kind of an interesting story. And they do give us a shout out at the very end. So little fun story. It's only like 10 minutes, but I thought you guys might enjoy that. But Gutta-percha is primarily zinc oxide. It's about 60 to 70, sometimes 80% of it. And that is the antibacterial property that we have. The zinc has some basic antibacterial properties to it. The trans polyisoprene is what comes from the tree. That is your Gutta-percha. That gives you that thermoplasticity that when you heat it up, it becomes plastic, and when it cools back down, it becomes solid again. There's going to be a little barium sulfate in there to make it visible on x-rays. And then the really big thing here is the waxes and resins that they add inside there as well. That is what's going to give you your different temperature, the handling properties. Sometimes there'll be dyes in there if they color the Gutta-percha. But this 1% right here, the waxes and resins, is what gives you all of your properties that we all care about. And so that's what makes them all different. So a little bit of OChem. Sorry, I actually enjoyed OChem. I was one of those weirdos. But Gutta-percha is in the trans form of 1,4-polyisoprene. And it crystallizes because it can lay flat. The cis form of 1,4-polyisoprene is actually the main elastomer in latex and a bunch of other rubbers, because it doesn't lay flat. It actually kind of congeals together in a different way. So it can't form those flat sheets. So that's your main difference there. I do apologize for the OChem, but this is why we required to take it. It wasn't just a weeder course. How do we get it out? There's 3 main ways of getting Gutta-percha out. You can dissolve it, you can heat it up, and get it out via friction. And so when we dissolve it, we're going to use chloroform. And there isn't actually a chemical reaction that occurs when chloroform goes in there. It's just a solvent. So instead of being layered in those nice little sheets, the chloroform picks it up and puts it back into solution. So that's why it becomes a big old mess. But now it's dissolved. That's why it's that liquid pink crap that's all at the bottom of your pulp chamber when you throw the chloroform. How many of you have heard that you can use isopropyl alcohol to harden it and make it a lot easier to remove? There's a fun little trick. So after you're done getting it out, you have all that little crap just everywhere inside the chamber, and it's super annoying. If you rinse it out with the isopropyl alcohol, it solidifies again, and you can almost scoop it out. Way easier to remove than the mush inside there. More OChem, because we all go through that. How that works is nonpolar chemicals are really dissolve really well inside chloroform. Polyisoprene is nonpolar. Isopropyl alcohol is not that great of a solvent, but it has a lot more polarity to it. And so when you mix those two together, what happens is it kicks the polyisoprene out of solution and solidifies. And so that's how this whole works. So we are done with organic chemistry. Don't worry, I'm not going to torture you anymore. Hopefully you all remember enough to realize why this is fun. Anyway, the next one is going to be the thermo and the thermoplasticity part of it. And how you're going to do that is by heating it up. This is the one that I have. It's my alpha unit from B&L. There's a great one from Woodpecker. You can do the touch and heat, the old school system B. And really, you guys still have to buy your obturation material, your obturation equipment.
Yes.
Yeah. If it goes bad, just get the Woodpecker one. It's cheap. It works great. It has a bunch of different tips. I just happen to have the B&L one because that was the only one available when I was in residency. I still have the one from when I was in residency because they last that long. These don't go bad, but get cordless. Don't get a cord. The only benefit of the System B, as you can see, I didn't mean to rhyme there, it gets up to extremely high temperatures. So both of these cordless ones are going to max out at around 230 degrees Celsius. This, as you can see, goes way above 600. So you can crank these things. There is a technique to remove thermafil carriers, which we'll talk about here, where you can actually do the system B, crank it up to like crazy high temperatures, and it actually melts the plastic. You then let it cool and pull it all out at once. It doesn't always work. And if it doesn't work, it breaks the plastic and it's a huge pain. So that would be the one to get. The final one is to use some form of friction. And so that's going to be some form of a file. And so what I did is looked at a few different companies. They sell retreatment file kits. So you probably have seen these before. Here's your Dentsply one. Here's SS White, which is a knockoff of the Dentsply one. Here's the Edge one, which is just a knockoff of the Dentsply one. And then the FKG has one that's kind of a knockoff, and the rest are a little bit wonky donkeys that are pretty cool actually to get stuff off the sides. What do you notice that is present in every single one of these kits? Something that's short and fat. And that is because of physics. When we look at the equation for stiffness, it's a constant, which is the modulus, multiplied by the cross-sectional area, how big is it, divided by the length. So said a different way, the longer the file gets, the less stiff it's going to be. And the skinnier a file gets, the less stiff it's going to be. And this is what you found, Emmy, when you're trying to use the 17 to get out that gutta-percha. It's too small for that, even that deep down. It works great if it only has to engage 1 or 2 millimeters. And so, once again, there's a reason we all took physics in undergrad. But the overall takeaway here, let me get this out of the way. There we go. There we go. The overall takeaway here is that you want to use shorter lengths when retreating. This is true for both hand files and for retreating. Though all those tiny guys are anywhere from about 16 to 19 millimeters, so they're much shorter. And you want to use those to remove the initial bulk of the gutta-percha coronally. Ideally, use thicker sizes because it's going to be stiffer, and so you can put a little more apical pressure with these. Heat treated, that's kind of up to you. There's sometimes when having that flexibility is useful, and there's sometimes when they're way too loose and it's not going to work. And in general, you want to spin faster because the faster you go, the more friction it creates, and you almost get that thermoplasticized effect as you're spinning it in there, which removes it more effectively. So I think none of this is out of what you've been taught. My go-to for every single retreat that we always start off with was an F1. I used the 21 millimeter one from SS White. It is heat treated because I do like to have a little bit of flexibility, but it's so thick at the top, it still has the stiffness that I need. Okay. When you are starting off to remove the gutta-percha, you want to have the file be thicker. What I want you to think about is the difference in an 08 versus an 04 going into the same piece of gutta-percha. If you try to do an 04 into that gutta-percha, it has to work the entire way down. This is how you break files. You want to have the file only work in about 3 to 4 millimeter increments at a time. So that's why we start off by using the heat to remove the bulk of it. Then you go in with a thicker, more aggressive file to remove the next 3 to 4 millimeters. And then we slowly decrease the shape and taper as we move down. So kind of a traditional crown down method for doing gutta-percha, because otherwise you're going to have a problem there. With these three things, dissolving the gutta-percha, using friction, that's going to get you most of the way. That should remove 80, 90% of the gutta-percha. Sometimes you'll get lucky and rip out a piece. You're golden. For the rest of the way, hand files are key. Same thing, start with the thicker sizes. I would start with like a 25 or a 20K file. An 8's not going to do you any good on these unless you're at the very apex. And really, that's only if it's been ledged or you need to get through a calcification. There are some other tips. So I like to use endo explorers when I'm retreating. And what you can do is after you take your heat down, go in and put a little bit of chloroform, and then take your endo explorer and actually push into that. What that does is it creates kind of a little purchase point for your file to grab into, and it also starts pushing the chloroform down into the middle of the gutta-percha, dissolving it from the inside out. This makes it so much easier to grab onto. Emmy, in yours, I don't know if you have an Endo Explorer long enough, but that could be a good way to grab into the Gutta-percha rather than getting into the ledge, because it's soft enough that with enough chloroform, you can even bend the Endo Explorer to kind of go along with that curve. That might re-engage it, and then you can use hand files to go further from that. SXs are really useful to remove. Like if you have a big oval distal canal, you can usually get the middle part, but those lateral sides usually have some gutta-percha stuck in there. I love using an SX spun fast to kind of brush out into that area. It pulls out the lateral gutta-percha really nicely. Headstrums are incredibly useful. I use headstrums on pretty much every single retreat that I do. We're going to talk about how to do Thermafil next, and that's a very big important part of it. And then there's also some other cool tips. So Plan B, terrible name for an endo company, like just terrible name. We all know this. The Pulp Sucker and Plan B, that you can tell that went through somebody marketing. And however, this is actually a pretty cool tool as well. It is a Endo Explorer with a little arrowhead at the tip. And so that's useful for pulling stuff up on the side. And they do also make ultrasonics specifically designed for retreatments as well. This is the one from Halsey that I've used a couple of times. It also has that little arrowhead at the tip, and it works extremely well. You don't use it at high percentage vibration. It just kind of works its way down and melts the gutta-percha, and then it gives your rotary file a little track to go down as well. So there's lots of different tips here. Other random things you can do. You can air slow speeds are latch attachments just like your other ones, and you can run them in there. Be very careful with this, but every now and then this is a tool you can pull out. I have activated hand files, so if you like Emmy and yours, if you get into that and you feel like you're in gutta-percha, don't pull out. Take your ultrasonic and hit it with it as you kind of screw in, and that will vibrate down further into the gutta-percha. That's the way we can get stuff out. Sometimes EDTA is necessary. That's mostly for calcified or ledged cases. Sometimes calcium hydroxide helps. I think it's just that you give your brain a break and you get to look at the case with fresh eyes that bring them back a few weeks later. Try different file systems. I have an entire box back up in there. Ooh, sorry. I have an entire box back up in there of random files that I've collected over the years, and I only pull them out once every 6 months. But you got to have that in the back of your head. So every time you see a new file system come out, throw that in the back of your head. Just, be like, okay, what could I possibly use this for? Because you got to get it out. But remember, there's always surgery, so don't kill yourself. You can always, if you're going to destroy the tooth trying to get that little last piece of gutta-percha out, it's probably more conservative just to do an apico if something does happen. And remember, our goal isn't to get every single little bit of gutta-percha out, just as our goal isn't to get every single little piece of bacteria out. We want to remove enough of the infection and the bacteria that the patient's own immune system could take back over and get you back. Okay, cool. All right, we got enough time to do this. Material-specific techniques. I knew this was going to be a 2-part lecture anyway, so we're going to get as much as we can done. I'll get you guys out in time. But let's start off with our carrier-based systems. Shout out to Dentsply. They did well enough to create the Kleenex of carrier-based systems, which is Thermafil. Everybody calls all the carrier systems Thermafil. St. Louis was probably one of the first major markets that they went into. I did so many Thermafil retreats in residency, and I truly do love them. With Thermafil, and I'll get on a soapbox here in a second, usually the cases actually look kind of pretty. They're well obturated, usually to the apex. They look really solid, but they're failing for some reason. And there's nothing better than being confused why the case is failing and getting in there and seeing those 3 little black dots staring up at you. It makes me know, okay, I know why it failed. So when we look at the instructions for use, and I've downloaded the actual instructions from Dentsply's website. You need to have a verifier, which is kind of like a K file, but it's not according to them. It must slip in easily up to the working length without force. This is what most people, when they use Thermafil, don't do. They don't check it with the actual verifier, and they don't realize that they're going to be short. And then when you insert it, it has to be slow, firm, and continuous. And what happens is they do that and they realize they're short where this stopper should be. And so what do? They push a lot harder. And what that does is it strips all of the gutta-percha off of that plastic carrier, and then it all fails. This is what I see 90% of the time. And this is the Louis method of it, because I have heard this from general dentists. If you are short and you're working through it, just use Thermafil. It's great because you can just shove it in there really hard and it's going to get down to the bottom and it looks great. And that's why Thermafil generally fails. It's not an inherent issue with the material. It's that it's used improperly by dummies like this little guy down here, who is here today. I know no one knows he's here, but he's good. And this is what you'll see. In this retreat, you can see that it looks decent. It's short, though. And notice how you can see the carrier, and this is all gutta-percha. That right here is where the gutta-percha stopped. And all of this is shoved out to the bottom. And there's no antibacterial activity in a piece of plastic. And there certainly wasn't celiac down there. And the idea is that as you push slowly, the gutta-percha should go in front of the carrier, taking it down. But instead, what happens is it just strips it all off, and then the tooth fails. So they came out with a new one, and they said, we're going to use gutta-percha that has been cross-linked. And that's where you get Gutta-core. Okay, so that's the other one you'll see. These, when you retreat, the core is going to be kind of like a reddish color. It's a little bit darker in color than the surrounding gutta-percha. And then there's the final one, which is metal Thermafils. Has anyone seen a metal Thermafil yet? No? That's good. They suck. We'll talk about them. The old school way of doing this is actually what they used to do. This is the original, way back when. This was the first Thermafil. He would take a 25K file. He'd take a thing of gutta-percha. He would heat it up with a Bic lighter and shove the gutta-percha into there. And that forms your carrier. And then you heat it up with the same Bic lighter and put it into the canal. This was the very, very first Thermafil back in the 90s. And there were definitely a bunch of dentists who did this as well because they were cheap. Thermafil is very expensive. That's the other thing about it. It is, last I checked, the regular one is about $5 to $6 per carrier. And Gutta-core is up almost to $20 to $10 a carrier. So to do a 4-canal tooth, that's $40 an obturation right there. So that's why. That's one of many reasons I don't like it. Okay, we will finish off with how to remove carriers because I know this is what all of you want to do. For the original Thermafil, that's mostly what you're going to be seeing. When you look down inside the canal, you're going to see that black dot staring up at you surrounded by a sea of gutta-percha. This is important. Make a hole just on one side. You don't want to go on both sides, and I'll explain why in a second. The first one you're going to do is use your heated tip, and you're going to take that down as far as it will go. Sometimes you'll hit a little bit of resistance. Keep pressing it. Keep having it activated. You usually can get down another 2-3 millimeters. That should get you about halfway down, roughly. Then you're going to take an F1 or whatever your preferred retreatment file is, the big thick boy, push down, and that should take you another 3-4 millimeters. Always get your working length beforehand from the cone beam, so stay short of it on you. Don't shove that down past the apex, obviously, but create the space. And now what you've done is you've created an empty space next to the carrier. What you're then going to do is take a headstrom file that kind of fits, and this is where you have to practice of doing this. You want to try a few different sizes. In general, larger tends to be better. Most of the time, for most normal size, like an F1 shape that was filled, I will usually use a 35 headstrom. That tends to work pretty well. If it's larger, I'll move up a couple. If it's smaller, I'll move down. But 35 is a good starting point. You will place it in there and then start screwing down. You want to get it to engage into the carrier. The plastic is softer than the headstrom files. Dentin is harder than the headstrom file, kind of. And you want to balance it between engaging the carrier, but not engaging too much of the dentin. So as you start to screw, you're going to then start to pull up. If you've done this for many years, like me, you can do it just with your hands. If you're first starting off and need a little bit of help, you can use hemostats, grab right where the rubber stopper is, and then lever against a cotton roll on the adjacent teeth. You don't want to do this on their teeth because you almost always get their lip and they do not like that. So put a cotton roll down, lever, and pop it up. I actually made a video yesterday that I'll send to you guys so you can see how it's done. I haven't done it like this in years, and I was remembering we were doing this and I had a good case to use it on. So I'll show you guys what that looks like. But it should grab it. If it's too hard to pull, back out a quarter turn. You're engaged into too much dentin. And 90% of the time, that pulls it out. If you were to remove gutta-percha on both sides, there's nothing for this to push against. So all of a sudden, you're going to have to be putting in 2 or 3 different ones, and it's a huge mess. This works almost every single time. It's a very, very effective tool. This is the key, though. Only remove it on one side. Generally, I will remove away from the furcation. Usually, the dentin's a little bit thicker there, and it's easier to grab into it. It just tends to be easier. So that's usually where I would create the space. If you don't get it, the next step would be to remove more gutta-percha apically to loosen it up. You can go down to a smaller file. So if you're using an F1, maybe switch to like a 2006 or a 1504 or something smaller to create a little more space to loosen it up. You can try different size headstrums, but if you still don't get it, well, that's where you have to start using your big brain and come up with a different idea. But have a plan, but be ready to switch it up. That's how we are going to do most of them. We'll finish up with gutta core removal. According to them, it's pretty easy. Gutta core came out when I was in residency, and they had us do a couple on plastic teeth. And you can kind of just take an F1 down, and it's soft enough to grab everything and pull it out. It usually comes up in a big mess, but generally, gutta core is actually pretty straightforward. Take an F1, you're good. For metal Thermafil retreatment, hopefully you don't have to see any of these because they are not fun. But it's the same technique as your regular gutta-percha. Sometimes you have to use some of the broken file techniques that we'll talk about as well. And with that, I think we will stop there and open it up for any questions that you all might have. Thermafils become easy, I promise. I know you don't think they are. I love seeing Thermafil. I get so excited when I see a Thermafil. I'm like, today's going to be a good day. We're going to get this out. It's going to be awesome. Metal Thermafils suck. Any questions?
What RPMs do you run it at?
I run it. Mine run at 550. That's the highest I can get my little Endomate TC2s to. I would do anywhere from 5 to 750, depending on what your motors can do. But you want to run faster. You'll be careful. You don't want to push, but you do need a little bit of apical pressure on these, way more than you would use on a regular root canal. On a regular root canal, I don't push more. So I'll never push my rule of thumb for how hard to push. I don't want to see those heat treated files buckle. So that's how little pressure I'm using. You think about like a 17, you barely push on it, it starts to bend. So I let the file do most of the work. With a retreat, I'm going to be creating a little bit more force because you do need to have it push apically. I push harder in the coronal gutta-percha than I do in the apical because obviously that's where you're going to have the bulk of material that you have to remove. But when you spin them faster, it's a lot easier. Other questions?
What about torque? Does that matter in this? Because you're spinning so fast.
That doesn't really matter. I mean, obviously, I have more than 0. But no, you want to have enough torque that it can spin. And with those larger sized files, you may find that you do have to up the torque a little bit. I don't change my torque ever. I use the max that those little guys do. They run on 1 AAA battery, so they are not putting out the same amount of torque that the wall units do. They're not super torquey. Like when I use the SX, it almost always triggers the auto backup because it's not powerful enough.
Great. Thank you so much.
Of course, if you guys have any questions about Thermafil, let me know. I promise this technique works like 99% of the time. It's such a good technique. You will be I have plenty of videos on Thermafil. You guys can watch. This is exactly the technique I use. It pops them out so fast every single time. And there's something so satisfying about looking in there and just seeing the little black carrier loose inside the tooth. You're like, I did it, you guys. This is great. So
can you
cool.
send us a video of the cotton roll?
Yes, I literally I took it yesterday. I haven't even edited anything. So yes, that's going to be on the. This is one where I had to use my big endo brain and still have something inside there that I have to get after. So don't get me started on this one. But all right, guys, have a fantastic rest of your day, and I'll see you all next month.
Thank you.
Bye, guys.